So I was at brunch the other day and a friend asked me, Tommy, how are pregnant people in Oklahoma doing these days? You know, a casual conversation topic. Well, my serotonin stable friends, not good. Not good at all. We've all heard the grim statistics, Oklahoma's sky-high maternal mortality rate, ranking 48th for reproductive care and last overall for women. But wait, there's more! A recent report from Pregnancy Justice shows that Oklahoma is 4th in the nation for criminalizing pregnant women. And I'm not talking about arrests for things like theft. These are prosecutions for crimes that are only applicable because a person is pregnant. What does that look like in practice? Well, that's where today's episode comes in. I get to shine a light on the stellar work of my fellow over-caffeinated colleagues Eliza Washington Harris and Caitlin Beasley. These two have worked tirelessly to put together a report displaying Oklahoma's treatment and prosecution of pregnant women with substance use issues. To give you an idea, when they started this project, Barbenheimer was the hot new rivalry, and we could all freeload off of our old roommate's parents' Netflix account to binge Love is Blind. Now I get it. Substance use during pregnancy can be a little uncomfortable to talk about, but let's be real. A very wise scholar once said in an episode of Policy in Pink while discussing STI criminalization with Kimberly Molitor, criminalization is bad public health. And what that great scholar said back then still holds true today. Jailing women for child neglect and abuse against their fetus because substances showed up in their system is bad public health. And that's for both mom and baby. But listen, I'll get off my soapbox because this episode isn't about me and my fabulous pontifications. We're here to elevate Eliza and Caitlin's fantastic work on the issue. So buckle up, Buttercup, because today we're diving into incarceration, fetal personhood laws, substance use treatment, and get this, a $17 million grant program earmarked to turn around Oklahoma's bleak outcomes for moms and babies. Let's get into it. So hello, friends. Can you all introduce yourselves and give a little bit of your background?
Sure. So I'm Eliza Washington, and I am the Data and Policy Research Coordinator at Matriarch. My background, I'm an anthropologist, and my background is in social sciences.
And I am Caitlin Beasley. I am the Policy Engagement Manager at Matriarch. I have a master's degree in the history of science, technology, and medicine, and I have worked my career doing not that. Spent some time at DIVIS, the Domestic Violence and Sexual Assault Response Agency here in town, doing communications and public relations, and then I'm here now.
So translation, we kind of just at Matriarch, but technically, we do have specific functions that are in our job descriptions, other than duties as assigned. Mm-hmm. What do you all do for Matriarch?
I kind of call myself the extrovert, but basically I manage our partnerships, kind of check in on all our partners, and then run any kind of communications-y type stuff that we do. So social media, if we get like a call from, media entities, I manage that process. And yeah, kind of some operation stuff.
I love it. It's the extrovert who doesn't host the podcast.
And I'm the research coordinator, so I deal with all things data related to Matriarch. So a lot of that, because I started last September, a lot of that is projects that I've inherited. So things like our lookbook online, where we deal with secondary data from a lot of sources and aggregate those in a way that sort of compares the Oklahoma status to the national level. And then our primary research, right now we're working on a project that we're going to talk about pretty soon here on pregnancy and substance use.
So Eliza, you kind of alluded to, you inherited this project for the substance use during pregnancy and that report and the whole, I guess there's no other word than project because it's a beast. Mm-hmm. Caitlin, I feel like you also inherited this project. And Eliza, you have the research background. Caitlin, how did you fall into it?
So we are part of the community action team that is a part of the Tulsa Fetal Infant Mortality Review Project. So that's a group out of the Tulsa Health Department that when there's a, and Eliza, I'm going to look to you to maybe speak a little bit more to what they consider an infant death here in a minute. But whenever there's an infant that passes away, they look at those case files. And then the group, like there's a clinical group that does that piece where they review all those and they find patterns like, okay, what are we missing? Why are we having, this specific issue seems to be causing a lot of mortality here. And then the community action team, the group that we're a part of, they take those recommendations that the clinicians have pulled out, these trends that they're seeing, and the community action team's job is to act on those. So out of that, substance use, like maternal substance use, they discovered that was causing a lot of infant deaths. So, and it kept coming up like every year. That's one of the things that the clinicians that are reviewing those cases are pulling. And so, and that was back in, I think, 2018 that the project first started. So that predated both of us even being a part of Metriarch, where that was like, hey, we need to do some research into this.
And in a year and a half, how many pages is it now?
What is it? Last count?
I think it's 50, around 50. So that includes like our methodology, qualitative report, and a policy report, and then policy recommendations.
It's just some casual reading.
Yeah.
Easy reading. So we've kind of alluded to this report. We've kind of talked about this project, but haven't actually explained what it is. And I like to think of this show as people teaching me things that I don't know. So what are we talking about today?
I think we're talking about the lived experience of people who have substance use disorder in our state and what that means for them on a community level, on an individual level, how they're impacted by the policies that we have in the state that are really, unfortunately, restrictive and tend to disregard reproductive autonomy.
And it's a really quickly changing situation. Like it's something that really since 2018 has accelerated in a way that is not the direction we should be going. We are basically policy-wise closer to moving backward than forward as far as best practice, what we know works and doesn't work. So I think that makes it a little more urgent of a conversation to be having.
And so can you all clarify kind of, I feel like we're using like these more flexible words here. Can you kind of clarify what is, substance use during pregnancy and what kind of is this concept?
I think substance use disorder is often referred to as addiction. Substance use disorder is a relatively new term for it that's used more in medical spaces to really highlight the fact that this is a mental health condition that deserves the respect and treatment of any other health concern.
Yes, and I think whenever you have someone that might have disordered use of substances and then they become pregnant, that adds a lot of complexity to that situation. And I think it adds a lot, for some people, a moral component to what should be still a clinically addressed issue.
So Caitlin, I think you brought up a really good question in reference to morals, because whenever you're doing a study as sensitive of a topic as this one, you have to take into account, the people who are participating and collecting their stories and just portraying it in an ethical way. How have you all done that in your research structure and just in analyzing the research itself? And I think also just the collection and gaining that trust. How are you doing the research?
Yeah, absolutely. I really love this question because in using qualitative data, there's always this question of how do I preserve the voice of my participants while also safeguarding their confidentiality and anonymity? The way that we've chosen to do that in this project, because we did interviews with people who have lived experience and who are vulnerable to criminalization and to stigmatization, we've done those interviews and aggregated that data into personas, first of all. So personas that are not necessarily one person's story, but aggregate several people's story into a sort of cohesive narrative that tells, this sort of journey of what pregnancy and substance use looks like in our state.
So we've seen a lot on the legislative floor and, in one pagers and all that jazz where research gets misconstrued or non-credible research is being used over and over and over. Can you explain a little more that what the personas are and that it's not an individual, but it's kind of like an amalgamation of credible real stories analysis? So can you explain why that is still very pertinent and accurate data?
Yeah, absolutely. Those personas are still coming from these lived experience voices. So we interviewed a total of 11 people, both in the lived experience side and care providers, things like that. And we took those stories from people who have lived experience when they talk about their early childhood exposure to substances, their socialization around substances through their family, and like all of these recurring themes that we saw throughout these interviews of early exposure to substance use, the fears that they had, those were pretty consistent throughout the stories that we had. And so what we sought to do with our personas is take all of those lived experiences and create one sort of symbolic person that summarizes those experiences in a way where we can talk about that a bit more freely without the concern of breaching confidentiality.
And I think an important thing to note here too is that those stories, when Eliza conducted most of these interviews and then uploaded transcripts of all of those interviews and went through and tagged that all the qualitative data that we had gathered and was able to pull out thematically, what are we seeing a lot of? So there's an underlying process that I don't think most people understand about how qualitative data gets from out of someone's mouth to your conclusions. There's methodology there, and it's very scientific in a way that people might not be as familiar with.
Caitlin, it's like giving me flashbacks of my master's project where I had to do that. And I didn't have fancy software because my school didn't pay for that. So I had to like sit there and do it in Word. So
Wow.
You're giving me like flashbacks on like sitting there at 3 a.m. Of course, the day before my first draft is due, trying to tag things and write it. So thanks for that. Thank you. Thank you for that.
It was like when I explained it, I'm coming at it like I didn't know this was even what qualitative research meant. I'm used to being in the archives looking at old dusty books. And to know that there's this really cool way of aggregating and synthesizing qualitative data with these software and watching Eliza, learning from Eliza how it's done, it's been really cool. It's a very neat approach to really, I think, getting at some of that stuff that numbers just can't do. Like numbers can't tell you what it is like to, get that positive pregnancy test and what do I like speaking to those fears, the very real experiences that people have.
So speaking on the kind of misconstrued data or non-credible data that gets repeated a lot, oh boy, a lot. How do you all plan and kind of take that concern into account when you're presenting this information? Because now you're presenting it to more people. You are now taking an issue that is really affecting the lives of individuals in Oklahoma, and you're putting a spotlight on it. Has that been something you've thought about, or even if you've taken the ethical and moral concerns around that, harking back to what we were mentioning about interviewing people?
Definitely. And I think when we are structuring those kind of conversations, thinking about how we want to frame this issue, I think we start with who are we going to be talking to? Because you have to meet people where they are at. So, and I think we can all understand that gut reaction when the first time that you learn about, oh my gosh, like this situation where you now feel how you want about when life begins. And we don't need to get into that right now, but like you now have two lives in some ways that are going to be affected by this person's medical condition whenever, there's someone that is using substances that may harm a fetus. So I think starting from that understanding, grounding, that is what we are talking about. And then what does the person that I am talking to, how are they going to understand that kind of situation? But we presented at an interim study where The committee was comprised of a couple of district attorneys and then a couple of, I think, ex-law enforcement that had turned legislator. And they have seen some of these folks on their worst day. They have seen kiddos in horrendously neglectful situations. So that's where they're coming from when we're talking about this problem. How can we get both of these people at the proverbial table so that they see these people?
I think to Caitlin's point, it's also just in general, it's scary to talk about any aspect of maternal fetal conflict in the sort of landscape of reproductive health that we have in the state. And so one of the ways that we have tried to address that issue or that concern, because maternal fetal conflict can be addressed through a couple of different ways. In our case, we specifically talked to all people who identified as mothers and addressing those concerns through really grounded policy recommendations and through lived experience voices. And going back a bit further, I think something that Caitlin also touched on is that we did this we did this with those voices in mind, but we also, throughout this research journey, have been keeping lived experience experts and clinical care experts in the sort of mix. We've been keeping those voices in the mix. And that began as early as writing out our research, our interview guidelines, our interview scripts. And when we wrote those scripts, we took them to a couple of experts and we were like, how does this sound? And what do you think about it? And how will people who participate in your programs, how will they feel about it? And yeah, we have just continuously tried to keep in mind our audience and the people who will be most impacted by this research. We don't want to blindside anyone who's working in this space.
I always love to hear when a study is being done and it's healthcare related and it actually has, practitioners involved. I know it's a shocker, but we've all seen those studies where it's like, who did this?
Mm-hmm.
Who made this question? Who classified it that way? So I think that was a perfect answer to kind of segue into talking about your interim study. And so for those who don't know what an interim study is, the legislature runs from February till the end of May. And then between that time, legislators can request what's called a quote unquote study. In reality, they submit a topic, and if the topic is accepted and the study is selected to move forward and actually be heard, the representative gets to pick a slate of people to speak on behalf of the topic. Not to sound too cynical, but they tend to be a little one-sided. So you did this study with Representative Blansett. She's based out of Tulsa, and she kind of was attracted to this study and really latched onto it and really was all in on this study and presenting this topic that, again, many people probably have not thought of, let alone heard of. So I think Representative Blansett kept bringing something up that Caitlin, I think, Eliza, also you were really alluding to, it, just like threading that needle of big feelings of that fetal personhood kind of, rights type thing. So how was presenting that interim study, and did you kind of see anything come out of it?
I think it would be funny to hear Eliza's answer to this, primarily because it was your second day.
Yeah.
Most of it is a blur. I was terrified. But I think that the general sentiment that I heard from legislators was a bit surprising in the because there was a focus on punishment without really understanding or without really reflecting on the sort of holistic piece. But yeah, I think there was a definite push for criminalization, and there was a lack of regard for substance use disorder as a mental health concern where people are deserving of respect and treatment and autonomy. So I think that was a challenge to sort of get over that barrier and say that there are solutions which keep in mind health of both mom and baby. And really that comes down to treatment and availability of treatment throughout our state. There are definitely some pockets which are less funded and have fewer treatment options as well.
So I want to intervene real quick before Caitlin, you answer, and we can come back. I'm now realizing that we kind of haven't gone over what the current state of things are.
No, you're good. And it's a bit of a complicated question, but that's why we're here to tease it out. Basically, what has happened. So in 2018, I'm just going to start there. There was a bit of a pretty big reform bill passed. I think you would have had to be looking pretty closely to recognize it at the time. But when you have someone that shows up to labor and delivery at a hospital with kind of this laundry list of indicators that there might be substance use involved, you have hospitals that will, for clinical reasons most of the time, if you've got a delivery that's going to be complicated by some kind of substance involved, you want to know that. So they will drug test. Then if that test is positive, is when things get kind of complicated. And what this reform in 2018 was kind of supposed to help fix, because it kind of sets off this process where the hospital is required by law to let DHS know.
And DHS is?
The Department of Human Services, specifically the Child Welfare Division that will be handling something like this. They'll report it, and DHS, Child Welfare, is supposed to have the kind of, because of this reform that passed in 2018, is supposed to have some autonomy or some power in looking into that, is there any other indicator that this child now, this is world side child, could be in danger? And if they say no, then they just record that as a substance exposed newborn and we move on. What is happening, especially in some of our more rural districts, specifically a couple of hotspots throughout the state where you have, instead of letting it go, the district attorneys are choosing to charge these women for felony child neglect, even when baby was born healthy, full term at times. And there's really no other indicator that this child has been neglected or is in danger. And we've seen that ramp up since 2018, which is, I think there are several factors we can talk about why that's happening. I think the marijuana being medically legal and widely accessible is part of that. But it's very strange that, and there was a case in 2020 where I don't actually remember exactly the details of the case, but it was some kind of substance that was definitely Schedule 1, where I think there was a miscarriage. And basically the Oklahoma Court of Criminal Appeals said, yes, you can charge a woman with felony child neglect for having a miscarriage when there is heavy drug use involved. And actually 6 months later, they said you can charge her partner too if he was helping her get drugs, which is interesting. And then after that, we see a pretty steep ramp up in criminalization too. So much so that we are now second in the nation for criminalizing people for crimes that were directly related to their pregnancy, often charging someone felony child neglect for having a miscarriage, or increasingly in certain counties for what otherwise might be a perfectly healthy baby.
So just to kind of put a button on that from a policy perspective to explain it, and what the huge ramifications of it is, the fetus is being given the same protections as I loved that term, world side. The fetus is giving full same protections as a world side of child. And that is kind of what's happening here. And that's what the prosecution is. That's the laws that are being under. Is that correct?
Yes. And actually, this is it's not funny because this isn't funny, but it's kind of funny. So the most recent case that actually it was ruled in a favorable way, but they basically, one of the DAs took to the Court of Criminal Appeals this idea that, so mom had a marijuana card, baby tested positive upon birth. they were making the argument that it still counted as felony child neglect, even though her use of the drug would not have been illegal with the card, because the baby, the fetus, didn't have a medical marijuana card.
And I just also want to tack onto that one, the bill that was introduced this last legislative, where it's like any minor exposed to any amount of even just like the smoke associated with marijuana was like severe child neglect. Oh, it was like, and it penalized the parent severely too. So a 17-and-a-half-year-old, back behind some building smoking would have penalized a parent. Luckily, that didn't go anywhere, and it was just ill written. But you never know in Oklahoma what's going to get traction. So bringing that all the way back, we just had this discussion of what is it? Where are we? This is where we're at now. Caitlin, you were about to kind of give a little answer on what was it like to kind of present at the interim study on this issue? Because when you all presented it, that was the first time a lot of people have heard about it. So how did it feel to kind of bring that into the spotlight? And did you see anything kind of roll out of it?
So it was a tough audience. And like I spoke to earlier, I mean, we can understand to some degree. I mean, these folks do want what is best for their community. They want to protect the children worldside or prior in their community. So they were very protective and interested in the well-being of the fetus. I think what surprised them, and what honestly surprised me, even like looking into this, learning more about what our best evidence-based interventions are at this time, 99% of them help both baby and mom. This division that's been created, I think, largely by these big feelings about the reproductive health landscape and access questions that are driving a lot of conversations these days, most of that is largely irrelevant. 99% of the time, what's going to help mom is going to help baby in the long run. We're on the same team here. So it was a lot of it was us and some clinicians, OBGYNs, talking about, here's what it's like to treat these patients. And I think that by and large, these guys were guys. It was all guys, except for Representative Blancett. I think they were receptive by and large. They had questions like, where is the line? When do we need to hold people accountable for not getting treatment? We gotta have this, and I'm quoting, this velvet hammer component to this conversation, or people will not be compelled to get better for their children, there's a lot of problems with that statement. But that is really kind of the belief, I think, that a lot of folks have. And I think that Dr. Angela Hawkins, who is currently she's leadership in this group of obstetricians and gynecologists. And she says, well, what do you mean, where is the line? There is no line. My job is to make sure that this person has everything that they need to successfully go through their pregnancy. What if, she was using as the metaphor, what if I have a patient that has gestational diabetes and, she's not managing that complication to the degree that I think that she should? Do we put her in prison for felony child neglect for not managing another condition that she's working through? No, there's no line. We support moms and babies, no matter what's going on. We do what's best for them. And I think that was a really compelling message.
I think you bring up a good message of one of the problems in Oklahoma as a whole when it comes to some of these policies is the policies end up being what feels good, whether it's good or bad. It's what feels good to whoever's proposing and passing and signing.
Yeah.
And there's not a lot of evidence and research-based interventions. And what I found personally in doing this for the last, 4 or 5 years was harm reduction is not something that typically is understood at the Capitol. It's not harm reduction, it's lock them up, which I think is coming back to that threading the needle that you all are talking about. And Representative Blancett was trying to allude to, and she was talking about this and presenting the issue as well, is this harm reduction. Because if we reduce, if we can address it with the mom, it's easier on the baby than just locking away the mom and who knows what from there. But segueing into that policy that came out of the interim study. So we kind of had two big policies. And of course, the one that was a huge success was Choosing Childbirth Act, which is an act that was originally made is $8 million to give to maternal health and infant health programs, but was pretty much just given to pregnancy resource centers, also called crisis pregnancy centers, which are, I am quoting this, according to ACOG, fake clinics that provide misinformation on reproductive health. That's a quote. I'm not saying it. Someone else said that. So that's kind of who was originally intended to give the money, but the money sat and it never went anywhere. So now it's been restructured and it's $17 million and it's much more opened up. One of the big successes was substance use was included in something that can be funded. Have you all talked to any programs, or do you know of like any programs that are kind of looking into that already? Or just what did it feel like to see that pass, that kind of your interim study helped push this into the spotlight?
So I think that it was really kind of interesting. We brought, in addition to like the research that we've been doing, kind of mapping out, where are the mental health clinics that these women can go to? We brought a lot of data with us to that presentation. But we also brought policy recommendations. And one of the ones at the very top of that sheet, it said, there's $8 million sitting out in this fund. And I remember it was one of the representatives that was there. He didn't say anything the whole time, but then I saw him looking at the recommendations, and he said, there's $8 million just sitting. And we were like, yes. So yes, they immediately latched onto that. And that was really cool. And it's really exciting to see. To get that money spent, because not only is that money moving, they added how much more, Tommy?
They reformed it. And so now it's much more open. So more people can access it. And that is a new $17 million fund.
But yeah, there are a lot of extant programs that have been working on this issue and trying to provide that clinical care that we know folks that are using substances and become pregnant, we know that they need. And that they would feel safe coming to these clinics that are specialized, and they're not going to get, reported to the police. So, and then there are prison diversion programs for moms who struggle with substance use. There are so many folks around the state that are working in and around this issue and supporting folks that are struggling with this issue. And so I think it'll be really cool to expand those programs. Hopefully some of this funding gets used for that. And then I also think establishing new programs specifically in rural areas. We have a huge deficit of that kind of support in areas of the state that really need it right now.
And some of the participants that we spoke with who were in programs with either the Star Clinic or a couple other places or Women in Recovery, how like their voices uplifted, like how passionate the care providers in this space really are about making change on an individual level and a policy level. And some of those voices were also at the table with that interim study as well. So yeah, there's a lot of really powerful and wonderful work happening here.
I wanted to kind of come back to that velvet hammer you were talking about, because the velvet hammer implies criminalization and punishment and penalty. Can you explain why that's not great? Because there was a bill through Representative Lancet that came out of this interim study that did kind of push this issue into drug court and into the legal system and into the criminal justice system. Can you kind of give a brief overview of why that's not good practice, and I guess calling back harm reduction?
I think like the first point I would say is ideally we would be preventative in the first place. We wouldn't be in a situation where criminalization would be anywhere near the table, because, our mom would have gotten in prenatal care. OBGYN would have identified substance use as a potential complicating factor. We would have gotten into treatment then. Safeguards in place. We're best prepared to take care of mom and baby throughout the pregnancy. I think that what a lot of folks don't understand is when you, this is really confusing to me, why this is not more commonly talked about. But when you incarcerate mom, where does that leave baby?
Oh, it's okay. Because about 2 years ago, we passed regulations that now you can breastfeed while in prison. So we're good.
Oh, yeah.
Oh, and women are no longer shackled while giving birth in prison. So we're good. We fixed it.
So frustrating because, okay, yes, breastfeeding is important. There's also just this whole, when baby doesn't have mom, they're growing up without their mom. And we know health outcome, like this, there's so much evidence supporting that if you can keep families together, that is always best case scenario for long-term health outcomes. The more institutional involvement you have, the more energy it takes to just do what you should be doing, which is taking care of your children. And then it tends to lead to more institutional involvement over a lifetime. So it's really just best if we can avoid that.
I think also on top of that is, the I can't remember the full term, but once incarcerated, there's then that kind of revolving door of continued incarceration throughout a lifetime. And so if someone is incarcerated for this kind of reason of substance use during pregnancy, it potentially creates that snowball effect of long-term experience in the criminal justice system as a whole. And, it also just interferes with job prospects.
Well, yeah. And felony child neglect. That's a felony on your record. It's just, and then we know that's a baby born with an ACE. Familial separation immediately. And
an ACE score is experiences that a child may have that has long-term impact on their lives.
I just wanted to add, on the topic of that sort of pipeline into prison, that punitive measure is also such a huge barrier to getting prenatal care. So we have evidence from other states who have implemented this sort of punitive piece of punishing people for substance use during pregnancy. And we know that it has an inverse impact and causes people to avoid seeking prenatal care. And that was also something that we saw in a lot of our participants as well, that they are afraid to go to the doctor and afraid to admit that they're using substances, and they delay prenatal care until very late in their pregnancy or altogether because of that fear of these punitive measures. So yeah, they don't really get the help that they need and deserve because of the stigmatization and fear.
And that really harkens back to kind of the STI discussion that we had this last session that no one expected to have, especially me, was criminalizing accessing healthcare does not promote accessing healthcare. If you criminalize, accessing healthcare through substance use during pregnancy or because someone's seeking treatment through STI, they're not going to go do it. It's a very simple concept. So as we come into that last piece of, what are the policies that would maybe address this? I know you all have a lot because I helped you work on them. So what would you say are maybe the three or the top three that are the easiest that could mobilize?
So I think I'm going to go high level and know that when the full report comes out, each of these buckets will have a lot of very specific recommendations within them. But I think first and foremost, promoting early prenatal and postpartum care, making sure that people are getting that care. That'll set them up best to take care of themselves and their families. Ensuring pregnant people have access to substance use disorder treatment services, in addition to that basic prenatal and postpartum care, especially in rural areas of the state. That is not happening nearly as much as it should be. The treatment centers just aren't there, or they're not there. They don't have enough bandwidth for the population that they need to be serving.
And importantly, the Department of Health here has explicitly said that they want to give those choosing childbirth dollars across the state. Yeah. So I think that's also great to hear that that's kind of like a policy piece that you've discussed.
Yes, definitely. And
I think also expanding those programs to include live-in with either existing children or the child that will come from that pregnancy is also a huge piece. Yeah.
Yeah, which is surprising that that's not a given. But some programs don't have that. I think that, I know that any facility currently, this is the law right now, any facility that is funded at all by the Oklahoma State Department of Mental Health and Substance Abuse Services.
Yeah, try typing that in a report.
We've done it a lot, written that out so many times. But if a treatment facility receives any funding from them, they have to prioritize admittance for pregnant folks. And I think they can't turn them away due to their inability to pay.
Yeah, but that doesn't mean that they will have programming that is specific to pregnancy and postpartum, which is also a tricky matter. So but they can't turn them away, but they also might not have the specialized programming or the resources and tools that they need to successfully treat someone who is pregnant using medication assisted treatment or things like that, or they might have fears about that. So that's a tricky spot to be in for a lot of our clinics.
You've all heard me go on tangents about how this policy is this policy is this policy is this policy.
It's all connected.
So we got two more buckets. We got to educate medical and other service providers throughout the chain of care on how to identify and treat or refer potential substance use cases, because you can get them in, but if you don't recognize that's like a portion of this person's medical situation that needs to be addressed, we're not getting any of those. Even if those things do exist, those programs do exist, if we're not identifying that that's a risk factor, we're not treating for it. And then last thing, establish and expand prison diversion programs that support women and mothers.
Is there any kind of last motivating, like rallying cry, elevator pitch, one-liner, something like brief that you could just put out there to say, go do this thing to make change? Or you need to know this? Because in Matriarch, we talk about that just knowing is enough.
I think my call to action really would to be really, truly understanding and acting on that understanding of substance use disorder as a mental health issue. If you ground in that, these policy solutions all make perfect sense.
I think I want to highlight just a small quote from one of our participants. And this quote is going to be the sort of lead to the title of our report. But one of our participants said, if I take time out of my life to go get treatment, I could lose my job. I could lose my kids. I might lose my apartment because I can't pay for it. And if not, I'm going to be behind on my bills for sure. The people that succeed at rehab are the ones that have financial resources to maintain a home and a job and take vacation time and all of those things. So the path to sobriety is probably a little more intense than people can literally afford to risk. And I think that that's such a sort of foundational piece of our project, is understanding that all of these pieces are tied in together and they all create barriers to care within our state.
And I think that is a wonderful teaser to end on for when this report comes out. It'll obviously be on the Matriarch website, so keep a lookout on that. Everybody, this has, I think, been wonderful. Did you enjoy talking to me? I did learn a lot more about the thing that you have been working on for the last year and a half.
Yeah, no, it's been a blast. Fun, interesting to just talk about it. We write about it so much. It's nice to talk about it.
Well, thank you both for joining, and everybody go subscribe to Fierce Facts on the Matriarch website to find out when it's fully released. This has been Policy in Pink, presented by Matriarch, a public health think tank dedicated to Oklahoma women. Join me, Tommy, and a parade of esteemed experts every other week as we discuss the political banter surrounding women's health. Find out more about the topics featured at matriarchok.org. That's matriarch with an E, a fun little play on matriarch and metrics. You can also find us across social media as Matriarch OK. Thank you to our producer, Rant9 and Jesse Ulrich. And once again, my name is Tommy. And remember, all policy is health policy.